Okay, chapter 7 is really about what we do as clinicians. So I'm going to use the PowerPoint so I can stay on track and kind of hit the highlights for you. I deleted a couple slides, but not very many. We've got about 20 slides to go through. So there's five primary stages: establishing a relationship and assessing or defining the presenting problem, identifying and setting goals, implementing interventions, planning, introduction, termination, and follow-up. So what is that? Build a relationship with the client, figure out what's going on, diagnose that, set goals to work on the problems, implement interventions to meet the goals, and then work to a point that they no longer need you so you can start either following up, transition, or termination. Okay, so stages of helping with establishing a relationship. And all the research that is out there, you can read that it doesn't matter what theoretical philosophy you come from, that the relationship that you build with that client will be the determining factor of their success. So it's extremely important to have a healthy relationship, a relationship where they know they can depend on you, they can trust you, and that you're going to be able to reflect back to them who they are in an open, honest, non-judgmental way. One of the things that I would say about building a relationship also is when you are giving that feedback to a client and you're reflecting that back, or you're giving that empathetic statement. One thing that people don't do very well if they're not really with the person is the empathetic statements. In my experience, a lot of people use this kind of practiced speech, if you would, like, and how does that make you feel? Or that must be very hard. And you say that so much that it lacks meaning. Like it doesn't have any realness to it. It doesn't have any genuineness to it. And if you tell me a story that is the hardest moments of my life, and the only thing that you can say back to that is that must have been really hard for you, then I don't know that you really heard me. So really working on those empathetic statements, a statement that says, wow, what that must have been like for somebody, and that person to know that you were in that walk and was trying to feel that with them. That is what true empathy is. Carl Rogers does not appreciate the standard feedback that must be difficult for you comments that we get now in counseling sessions. So real empathy will go a long way. Motivational interviewing is a type of theoretical approach, but it can be used in so many ways because it really works really well with people, especially when they're not motivated to change. It really allows them to lead the session. It allows them to prepare themselves ready to start working on something. You always want to have a collaborative relationship with your clients. You don't want to be like, well, this is what you need to do, blah, 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 blah. If I'm working with somebody and I say, like, something's going on, I'll say, well, some things that I think we could do is, and I give them options, always give them options, always kind of ask them what they think that they could do next. You want it to be a very collaborative relationship. I don't care who we are much more willing to participate in something if we feel a part of it and not told to do it. It's just human nature. It's also really good to remind people that they do have natural resources, support systems, and to utilize what they already have in their own strengths. And again, we've talked about this once before, but it is always our job to let the client lead their own path and make their own decisions. and live their own life. They need to be self-directed. The second, when you build in that relationship and you're getting all that information, it's really hard because when we're doing assessments and gathering information, a lot of times we have a very short window to gather the information, and that makes it hard sometimes. But just because you gather that information and that intake, and then you give a diagnosis or whatever, at the end of that first initial meeting, doesn't mean that those things can't continue to be assessed and those diagnoses can't be changed at a later date. So assessing and defining the presenting problem. The relationship that you build with that client in the discussions and getting them to tell you who they are in a very truthful and holistic manner is the main part of your information gathering stage. The decision making is once you get all that information, that's when all the things that you've been training for, you put it in that theoretical analyst brain of yours and you start making decisions about which way to go with it. And it also can lead to more precise questionings. It can lead to more specific assessments, like assessments for depression, assessments for anxiety, different types of assessments to be done. And it starts allowing you to formalize a plan that you feel like you want to put this client on the path that you feel like that they're on or need to be on. We also use assessments to make sure whatever we're doing is working. So you can use assessments in the beginning, but you can constantly use assessments throughout too to see if things are improving, because you want to evaluate your treatment. One of the most difficult things is diagnosing somebody, because you have to accept the burden that you are putting a label on someone. There's a lot of things that make people very nervous about diagnosing somebody. Sometimes we're afraid to put too heavy of a diagnosis. Sometimes they just don't meet all the criteria. Sometimes we realize we didn't ask the right questions after they leave. It's definitely a skill that the more you do it, the better you get. But one thing you need to always know is don't ever be afraid to pull out that DSM and look it up and ask yourself some extra questions, follow up. It's really, really important to just take your time and begin to trust yourself. And it's always okay to seek someone's advice, supervision, and kind of bounce it off of there till you get it where it's more comfortable for you. It talks about all the different things of functioning. If it is a diagnosis, then your function level has to be impacted. So you can have anxiety, but if you can still fully function with that anxiety and it doesn't prevent any problems in your life, then it doesn't become a diagnosis until it impacts your functioning level. Types of other information that you're going to gather is demographic, presenting problems, what's going on now, their functional level, biopsychosocial history, family history, and constellation. A lot of times you want to do like the family trees and see if you notice some trends there, and any behavioral observations that you notice yourself. There will be times that you want to do a mental status exam because you maybe feel like a client's not fully oriented. When we provide a diagnosis as a clinician, we're more apt to say stuff like generalized anxiety disorder, major depressive disorder, bipolar. But one of the things that we need to recognize is you have the ICD-9 codes, and that's the billable codes. That's these codes behind the scenes that people often don't know by number unless you're in that medical field. And they match up with our DSM. So if you look in your DSM 5, you'll notice that they are coded, and those codes is what matches your ICD codes. The next one, you can get the ICD codes for free. They can be downloaded from the WHO website, just so you know. And it says all mental and behavioral codes begin with the letter F. So when you look at your DSM, you'll notice that those like first parts of the before the words like bipolar or depression or anxiety, and I think it gives us some good examples here in a minute, they start with an F code. The DSM and the current DSM is DSM-5, and the ICD is ICD-10. So obviously they have went through many stages of change, and so toward the ends of this we're going to go over just some of the few changes that it changed from the DSM-4 to the DSM-5. Some places are still using the ICD-9 codes too, but those are all trying to get changed over. So here's you a couple of examples. So from F01 to F09, so that range there, those are your psychological conditions. From 10 to 19 are your behavioral due to psycho, so those are your addiction codes. 20 to 29, those are your schizophrenia, delusional type disorders. 30 to 39, mood affective disorders. 40 to 49, anxiety, stress related, non-psychotic types of mental disorders. 50 to 59, behavioral syndromes associated with physiological disturbances and physical factors. So for examples of those, like you've got F10, 23, that's alcohol dependence. F40, agoraphobia. So they're in those categories as the behaviors. The DSM-4, some of the big changes that they made from 4 to 5 was they removed the 5 axis. So if you get an older chart from a client who was previous in services and they were diagnosed using the axis 4, you're going to notice that their chart looks very much different than the ones you're currently doing under the DSM-5. If you get a chart and you see like these Roman numerals 1, 2, 3, 4, and 5, then you will know that they were diagnosed using the DSM-4. And the DSM-4, the way that looks is they separated Axis 1 and Axis 2, separated the types of mental disorders. So the mental disorders on Axis 1 would be like your depression, almost all of your DSM diagnosis, except for on Axis 2 they would put personality disorders and ID disorders. Axis 3 was any medical conditions you had, asthma, heart disease. Axis 4 was for any type of environmental impact, like homelessness, loss of income, or any type of history that needed to be made note of, like a victim of sexual assault. And then your Axis 5 was a number from 0 to 100. Axis 5 was your functioning level, so the closer to 100 that you had, the better you were functioning. And now we don't have those anymore. We will have the codes, we'll have specifiers, and now we have what is the V codes, which is what we use for those environmental things or history or even medical conditions. Some of the revisions from 4 to 5, there was revisions with autistic. The revisions that they made for autistic disorders is they put everything on the spectrum, and they took out any of the other diagnoses like Asperger's completely out. So everything is on a level of the spectrum. Binge eating disorders was moved to a main section. DMDD, disruptive mood dysregulation disorder, was put in there, and that is a diagnosis that is often used with adolescents that when they're actually depressed, but they look like they're more angry. So it's depression exerted outwardly. Ascaration, which is skin picking, was added. Hoarding disorders was put in, and then personality disorders, they use more of a trait approach instead of some of the previous diagnostic criteria. They removed bereavement, substance use disorders. There was some changes in the addiction section. And PTSD was put with trauma and stress-related disorders. Okay, so that's the assessment and diagnosing part. Once you have that assessment completed, once you know the diagnosis, then you can start your strategic plan of what you want to do, how often you want to do it. Never set your clients up for failure. Always think about the fact that if you're wanting them to implement something, then make it a doable number. If I said all of a sudden, like I wanted you to go to the gym, saying that you're going to do it 100% 7 days a week, I'm setting you up for failure. Trying to implement something that is possibly not doable. So it's okay to start out with 2 or 3 times a week, or to try something once before I see you again, because you can always increase the number of how often someone's going to meet a goal, and it's better to do it in increments than to set them up for something that's not doable. Things that your treatment goals need to say in it is who's going to do what, how often they're going to do it, and what time frame. So it might be something like Jonathan will monitor his cognitive thoughts when he is anxious and write them down at least 3 times this week, and implement a coping skill over the next 14 days, something like that. And then that takes you into the implementing interventions. So once you know what you're combating, then you want that person to say, okay, I recognize the symptom, so now what interventions? And so when I work with somebody, we'll stay with Jonathan. If I work with somebody and I know that they're having anxiety, then I might offer them like 5 or 6 different interventions and go over them briefly and say something like, okay, Jonathan, so some of the ways that you can work on your anxiety is to keep a daily journal, just a number that says, what was your anxiety level today? Something that we can follow. There's some breathing exercises that you can use to decrease your anxiety. I want you to monitor your physical reactions. Do you notice, like, if your anxiety is raising, do you notice increased heart rate? Do you notice that your jaws are tension? Do you notice your palms getting sweaty, shaking your foot, popping your knuckles? There's some guided meditations that's helpful to calm somebody down when they're anxious. There's specific belly breathing. So I would go over all the different techniques that I'm aware of that are pretty effective, and then I would let that client choose which ones of those they want me to go into more detail, maybe model through, that they feel like that they would actually do, because I want to give them choices that they can choose for that seems more like them, their style. And then we develop the treatment plan with those goals of how often they're going to do that and what that's going to look like. And that's our therapeutic contract. That treatment plan is our therapeutic contract that says this is what we're going to do, and we're going to evaluate that every time you come in and work on those. And depending on the way that you work on them, that depends on if it's going to be individual counseling, if it's group counseling, psychoeducational, family, all the different ways of how you're going to provide that service. The only thing that we haven't talked about here is consultation. Sometimes we work as a consultant instead of a therapist, and that's when we're giving advice as a third party. We're not actually involved in the treatment. So that could be a supervisor giving feedback to another therapist. They're consulting with that person. And sometimes in family counseling also, there's more than one provider, just to kind of have more support, as well as in groups. So all three of these here can have multiple providers, because sometimes in psychotherapy groups you have a leader and a co-leader. Sometimes in family counseling you team up if it's a big family, just in case somebody, both of those is because if somebody goes off or gets upset and leaves a session, one person can go with them and somebody else can lead. And then, like I said, consultation is still two professionals. A lot of time the clients never meet the consultant. In group work, you have different ways. You have advocacy, case advocacy, class advocacy, professional advocacy, and quiet revolution. Okay, so with group work, you have advocacy. So obviously you're advocating for something. But advocacy can work different ways. You have case advocacy. So that's where you're taking a specific case, just a specific case, and you're trying to get services or funding or something specific for that specific case. Class advocacy would be where you maybe are representing all of the children. So maybe you're working with drug court kids, and so they're all children that are minors in drug court, and so maybe you're trying to represent an interest for that entire group of a need. And professional advocacy is for you're advocating for the profession itself. So something like that's going on professionally right now is we have been fighting as a profession for many years to be able to work in like VA hospitals, and we've started getting our feet in the door. And then quiet revolution. So when you talk about quiet revolution, it's talking about trends, and so some of those trends could be how we've gotten licensure in all 50 states. All the boards are regulating. KCREP is making specific standards for education coming up. Those are things that are kind of quietly happening behind the scenes that people don't really see. But it does absolutely help provide more professionalism and standards for mental health counselors. And the last one is planning and introducing termination and follow-up. Once your client is doing well and they're maintaining, there should be a discussion of termination, or sometimes when clients are nearing the end of services, they may fear leaving you, and so you might extend, like, well, instead of coming every week or every month, you're going to say, I'm not going to see you for 3 months, to have those little check-ins. And then sometimes some treatments, they have booster sessions where they'll do like family services, and then they'll say, come back in 6 months and we're going to do a booster session or a follow-up session. So however your treatment transitions and phases out is the last part of that, and it needs to be discussed from the beginning how that looks. Some of the biggest trends for mental health is going to topics like evidence-based practices, increasing our research, and that we're doing treatment that shows efficacy, being able to rely on multiple different approaches, working with clients more holistically. Those are all big trends that are being pushed. Client-led care is another one. Strength-based approaches, trying to work on increasing resiliency through education and prevention. And final thoughts, conclusion. of all these, I think that flexibility, knowing that everything is changing, as soon as you get used to something, it'll change and you have to do it a different way. Paperwork's always going to change. It comes from way above all of us and trickles down, and you just need to expect it so that it doesn't bother you so much. And take care of yourself. Self-care is so imperative. You have to think about the fact that you walk around with a closed vault with everybody's worst moments of their lives in your head. You have to find a way to compartmentalize that and be able to have a life outside of your job, to take care of you, to keep your life fulfilled so that you don't cause yourself to be unhappy, burn out, take on so many other people's issues that you have vicarious traumatization from it. So your self-care is absolutely imperative, which is why in this class you do a self-care plan. So that's all of Chapter 7.